It's not moving. Okay. So the flow of the presentation will include the introduction to the emergency medicine, short formed as ED or EM, and we will go into perspectives of global and Indian timescale of the developments. We'll give a glimpse of what is happening in SGPGI in the EMRTC for a 1 month depiction of what actually happens, enough to understand the problems and the solutions. Our solutions are not our solutions, but they are some of the solutions that are there. It needs to be tackled at a much higher level than us dealing with all the problems and all the solutions. And then we go ahead with the Niti Aayog and the organizational and the operational challenges of the ED. We also go into the observations and the recommendations for improvement of the Department of Emergency Medicine overall in the country. And we also look into the future aspects of emergency medicine, and then we summarize the entire presentation. So to start, I would say it's a field of practice which is based on knowledge and skills which are required for prevention, diagnosis, management of acute as well as urgent aspects of illness and injury affecting patients of all age groups with a full spectrum of undifferentiated physical and behavioral disorders. It can also be considered as the most interesting first 15 minutes of every other specialty. The ED is a unique operation which is optimized to exist at the edge of chaos. The word is edge of chaos. It comprises the delivery of time-sensitive interventions which are needed to avert death and disability, and for which delays of hours can worsen a prognosis or render a case less effective. So what is EM? So EM is for anyone, say for any patient, it is at any time, it is for any sort of emergency coming in, walking into the ED. It sees undifferentiated patients with symptoms and not diagnosis. It's early in the disease course when typical presentations of disease are yet to develop or still developing, and then make decisions with minimum of information that is available to you. So that is the unique aspects of emergency medicine. Going into the global and the time scale developments, this is the global time scale of emergency medicine. The word as such started in 1630 when the term emergency was first coined, and Dominique Jean Lery, a French military surgeon in the Napoleon's army, is probably the most reputed person in the emergency medicine, who's initiated. He's also called the speed surgeon, doing 24 amputations in 24 hours, and is one of the landmark figures or the stalwarts of emergency medicine. And he initiated the flight chariots and the flight ambulances that we know of now are different kind, but at that time it was called the flight chariots. And the word from there, it went on to starting of ambulance services in US, and then the first recognized emergency medicine was started in South California, University of South California, and the specialty as such was recognized by the American Board of American Board of Medical Studies in 1979. Now, China started it in 1989 as a specialty. Why China is being talked of is because they are the maximum population, and India being the second. So China started it in 1989, and out of the 11 of the 27 EU countries already had emergency medicine in 2007 itself, so when the EU was being made. And India recognized the specialty in 2009. The MCI recognized this specialty in 2009. So there are two models of emergency that go about in the world. One is the Anglo-American system, and the second one is the Franco-German system. Now, the Anglo-American one is dealt with in Australia, China, Japan, UK, and US, while the Franco-German, as the term says, France, Germany, Austria, Russia, Sweden, and Switzerland. But the main differences between the two is that, do you want to tackle the emergency right at the site of the emergency, or you want to bring these patients to the hospital where there is an academic emergency medicine department? That is the main difference if you go into. So the main motive is bring the patient to the hospital in the Anglo-American style, well-equipped and skilled hospital-based academic emergency medicine departments, while the Franco-German believes in the bring the hospital to the patient. So the provider of care in the Anglo-American variety is the paramedics with a medical oversight who will be going to the site and bringing these patients to the academic EMs. While in the Franco-German, there are medical doctors itself who work as the main persons who go onto the site and deal with the situation. So in the Anglo-American, it is less treated on the scene, it is more transported to the hospital. While in the Franco-German, it is more treated on the scene and few of them get transported to the hospital. In the Anglo-American, it's a direct admission to the emergency medicine, while in the Franco-German, it is more direct admission to wards, bypassing the EM. The future development for our country is on the same lines, and the Anglo-American is not switching over to the Franco-German, but the Franco-German is trying to now develop their EMS systems so that it becomes at par with the Anglo-American style of management of emergency medicine. So what is India doing? The initial phase is hospital-based academic emergency medicine. So this is what India is doing. But in the later phases and the simultaneous phases, in some places, it is strengthening the pre-hospital emergency medical service as well. So for in India, this is hospital-based academic emergency medicine is the way forward for now, with more enhanced and developed pre-hospital emergency medical services. So the timeline of emergency medicine, as I told you, in 2009, it was recognized as a specialty. In 2010, 2 government medical colleges in Gujarat started these academic emergency medicine department, followed by AIIMS and 3 more private medical colleges in South India. But from 2011 to say 2020, there were only 37. This is the NMC website data, which shows just only 37 PG seats in 2014. So looking at the time scale and the slow pace with which it was picking up, so the NMC decided to make it a mandatory clause that all medical colleges who are vying to get recognized must have an emergency medicine department with them. And in UP, PGI happens to be the first recognized or permitted department of emergency medicine. So currently the total number of seats in EM stands at 187. Total medical colleges which are there are 58, of which the government seats are 89. You can see them, the blue ones. Most of the private colleges in the south have got emergency medicine, many of them recognized. And the first medical college to start the emergency medicine was in Gujarat, in India, and in UP, we are the first ones to start it. So the time scale in PGI starts in 1995, where there was a ERS escalated from 4 beds to 10 beds to 20 beds to then 30 beds, primarily meant for specialties of the super specialty divisions, where the patients were knocking on the doors of the hospital asking for care. So this was more of a super specialty EDs which were requesting care for the emergency related aspects of their management. So it escalated with 4 beds, 10 beds, 20 beds, 30 beds. And on the 17th convocation, the Honorable CM of then time, Akhilesh Yadavji, initiated the creation or announced the creation in 2012. With 2013, there were already faculties from other departments who were looking into these areas and as an additional responsibility. However, the regular faculties came only in 2018. 2019, the first PDCC in resuscitative emergency medicine was started. From 2020 to 2021 were 2 years primarily involved with COVID cares, with EM getting involved with all the aspects of COVID care, including everyone in PGI. And at 2021, somewhere in between 2021, the NMC approved the admission on 2 seats. And so the first PGs joined in 2022. So, and the EM at that time simultaneously shifted to the new building. Now, with that brief introduction, I'll bring in my PDCC student, Dr. Swati, to give you a glimpse of 1 month of what is happening in the emergency at EMRTC, enough to understand. We can give you a 1-year data, but what we are understanding in 1 month is not going to be very different from what we understand in 1 year. So I'll bring on Dr. Swati now.
Thank you, sir. Very good morning to all. As sir has mentioned, we'll be discussing about a glimpse of the SGPGI ED at EMRTC. We start with the graphical representation of the annual footfall of the patients in the OPD on the left-hand side and the EMD on the right side. A brief detailed description of the same for the year 2022 will be discussed on the right upper corner of the slide. As of year 2018, the total number of patients that presented to the OPD was 6 lakh. 51,000 of these patients were admitted and 1,497 patients expired. As of the same year, approximately 30,000 patients presented to the EMD, out of which 3,354 patients were admitted and 268 patients expired. And so on and so forth for the remaining years of 2019, 2020, and 2021. We now discuss a brief detailed description for the year of 2022 until July. As of July 2022, the number of beds in SGPGI are 1,600, out of which 30 beds belong to the ED, which comprises only 2% of the total bed strength of the SGPGI. The total footfall of the patients for the year 2022 until July was 3.1 lakh in SGPGI. 15,000 patients presented to the ED, that is 5% of the total footfall. The number of admissions in SGPGI were 20,000 for this time period, and 1,534 patients were admitted to the ED, that is 8% of the total admissions at the SGPGI. 724 patients expired during this time period at SGPGI, out of which 172 patients expired in the ED, that is 24%. Now, if as and when EMRTC starts working at its full bed capacity, the number of beds that in the SGPGI will increase to 2,158. Simultaneously, the number of beds in EMD increased to 210. Thus increasing the total percentage of the beds in percentage of ED beds in SGPGI to about 10%. A brief description now will start of the snapshot of ED at EMRTC for the month of June 2022. The number of patients that presented to the ED during this time period were 2,254, out of which only 542 patients were received on the stretcher. Rest patients were directed and channelized to areas like the OPD or waitlisted for admission. Out of the 542 patients that were taken up on the stretcher, 220 patients, that is 40.5% of the patients, were admitted to the ED. 122 patients, that is 22.5% of the patients, were transferred to specialty ward or ICU. 196 patients, that is 36.1% of the patients, were discharged from the stretcher. And 4 patients, that is 0.7% of the patients, expired on the stretcher. The age-wise distribution of the patients that were admitted to the ED, that is 220 patients. The mean age plus minus standard deviation for the 220 patients was 51 years plus minus 18 years. 27% of the patients belonged to the age group of 50 to 60 years. 18% of the patients belonged to the age group of 40 to 50 years. We can see here that 30% of the patients belong to the age group of more than 60 years of age. And the pediatric composition of the patients was only 5.8% of the patients. The gender distribution of the patients admitted to the ED, 64% of the patients were male and 36% of the patients were female. The type of patients that presented to the ED and were admitted, only 75 patients, that is 34% of the patients, were follow-up of SGPGI. Rest patients, that is 145, comprising 66% of the total admitted patients, had their first visit at SGPGI. The comorbidities of the patients admitted to the ED, comorbidities like hypertension, diabetes mellitus, chronic kidney disease, chronic liver disease were present in 31%, 30%, 28%, and 27% of those admitted to the ED. Coronary artery disease and stroke were present in 8% and 3% respectively. 2% of the patients were post-renal transplant patients. The symptom-based presentation to the ED comprises of 18% of the patients presented with abdominal pain, 17% presented with fever, 15% of the patients presented with shortness of breath, 13% presented with bleeding manifestations, 11% with altered sensorium, and other non-specific complaints like jaundice, anasarca, and chest pain were present in 26% of the patient. We can see here that patients with snake bite, poisoning, hanging, etc. did not present to our ED during this month period. Now we'll discuss the specialty-wise distribution of the patients admitted to the ED. A percentage of 40% of the patients had their primary illnesses related to gastromedicine. Diseases like chronic liver disease, acute on chronic liver disease, pancreatitis, both acute and chronic, were present in the majority of these patients. 23% of the patients had their primary illnesses related to nephrology, comprising of chronic kidney disease, acute on chronic kidney disease, etc. 6% of the patients belong to pulmonary medicine, 5% belong to neurology, 3% to urology, 2% to cardiology, 2% to hematology, 1% to endocrinology, and 1% to radiotherapy. The other specialties had the other patients had illnesses belonging to more than one clinical category or belonging to other specialties like neurosurgery, endosurgery, gastrosurgery, etc. The ED-based management of the ED management-based clinical spectrum of the diseases will now be discussed. 47% of the patients had sepsis and multi-organ dysfunction syndrome. 22% of the patients had acute kidney injury. 11% of the patients presented with respiratory failure. 9% with GI bleed. 4% with encephalopathy. And 7% of the patients presented with hematological dysfunction, including anemias, cytopenias, and leukemia. The interventions performed on the admitted patients during their ED stay included the oxygen inhalation, nasogastric tube, Foley's catheterization, peripheral and central venous catheter, and radiological imaging were done on the patients as per need basis. For patients with GI bleed, 80% of the patients underwent interventions in the form of upper GI endoscopy or colonoscopy. For patients with renal dysfunction, 90% of the patients underwent renal replacement therapy. For patients with respiratory failure, 60% of the patients required support in the form of BiPAP or mechanical lung ventilation. Patients with sepsis and MODS were managed on the basis of surviving sepsis campaign guidelines. Rest all patients were conservatively managed, including patients with hematological dysfunction requiring transfusion support. We now discuss the radiological imaging that were performed on the patients during their ED stay. 200 patients underwent X-ray imaging, 186 patients underwent ultrasound imaging, 35 patients underwent imaging-guided PCD, percutaneous drainage, and 30 patients underwent CT imaging, and 10 patients underwent MRI imaging. Of the X-ray and ultrasound imaging, 160 patients undergoing X-ray and 120 patients undergoing ultrasound, these were performed on the bedside for the patients. Also, I would like to point out here that imaging like MRI, CT scan, and imaging guiding percutaneous drainage at present are not present in EMRTC. We now discuss the type of discharge for the patients admitted to the ED. 99 patients, that is 45% of the patients, were discharged from the ED. 89 patients, that is 40% of the patients, were transferred from the ED. The transferred included 97% of these were transferred to the ward, and only 3% were transferred to the ICU. 12 patients, that is 6% of the patients, went LAMA, and 20%, that is 9% of the total patients, expired during their ED stay. When discussing the type of discharge, I would also like to discuss the length of stay for each type of discharge. For convenience purposes, we have distributed the length of stay as 1 to 3 days, 4 to 6 days, and more than 6 days. We can see here that among the patients that got discharged from the ED, 83% of the patients had a length of stay of more than 3 days. The transferred patients, 43% of the patients had a length of stay of more than 3 days. Among the patients that expired in the ED, 80% expired within a span of 1 to 3 days. The gross length of stay for all the patients that were admitted during this time period, more than 61% of the patients had a length of stay of more than 3 days. The length of stay of the patients who expired during this time period, more than 50% of the patients expired within a span of 24 hours of their presentation to the ED. The cause of death for the patient that expired during their ED stay, as per the issued death certificate, 80% of the patients had multi-organ dysfunction syndrome. This is the category of patient that needed the ICU care. 20% of the patients expired because of cardiogenic shock. The secondary causes of death for these patients included sepsis, septic shock, decompensated liver disease, acute on chronic kidney disease, and acute coronary syndrome. The underlying illnesses that were present in these patients include chronic liver disease, diabetes, hypertension, chronic kidney disease, and a combination of these illnesses, rheumatic heart disease or coronary artery disease. The SOFA score on admission of the patients that expired during their ED stay was 2%, in 2 patients, that is only 10% of the patients, the SOFA score was less than 10. In a majority patients, that is 75% of the patients, the SOFA score was more than 10. The predicted mortality for SOFA score of more than 10 in ICU is more than 50%. Now I would like to call my head of the department, Dr. R.K. Singh sir, to discuss some problems and some solutions for the above.
Thank you, Swati. This snapshot is enough to explain. If I give you a snapshot of, say, 1 year, I think probably I'll reach the same point. So I'll just enumerate some of the issues that can be tackled at our end, some of the issues that need more of administrative inputs. Now, you look into problems of any ED, may it be US, may it be UK, or may it be India or Africa. These are the basic problems any ED is going to go through. There'll be waiting times, patient acuity, border volumes, ED volumes, staff dwell times, waiting times, ICU volumes, door-to-door admissions, short-term returns, daily discharges, occupancy rate, throughput, completion times, and hospital volume. But you see, the two most important for any ED is the length of stay and the overcrowding. Both of them are interrelated to each other. The more the overcrowding, the more the length of stay, the more the length of stay, the more the overcrowding. So all EDs worldwide deal with these problems, and it is not at all news to us that we are also on the same boat as the world is. Now, we divide these problems for the length of stay into 3 segments: one, the input, the throughput, and the output. And each of these areas can be tackled, can be enhanced, can be increased, the qualities can be increased. But for the ED that we see in PGI, and doing a fishbone analysis, if we do, this is going to be an exit block that we see in the ED, and this is the most important and common reason why the ED length of stay is more than 3 days at SGPGI. The causes are multifactorial. More complex patients, we are a super specialty tertiary care center, so we receive more complex patients. There is an increased geriatric population, as was emphasized. More than 30% of them are geriatric. We're receiving multi-organ dysfunction patients. Non-urgent admissions are occupying a fraction. I will not comment on the percentage, but yes, a percentage of them are non-urgent admissions that are occupying our spaces. There are shortage of bed in ED and wards, not alone the ED, but also the wards. This is important. If there are shortage of beds in the wards, then the exit block is bound to happen. So there are shortage of beds both in the ED and the wards. There are shortage of care, acute care beds. There is no ICU in the ED itself. So there is no ICU in ED for the moment. There are staffing shortages in the ED. There are interdepartmental communication and coordination issues may also be a part of this multifactorial problematic issues. Round-the-clock availability of bedside therapeutic and diagnostic interventions. So the daytime interventions will happen, but the nighttime interventions may be a little more slower process. So the disposition times may be more prolonged, and therefore the ED length of stay may also be increasing. Round the clock availability of point care laboratory services, again, daytime more apt, in the nighttime it may be a slightly lesser. Ease of access, now everybody has an access into the ED. So the number of patients walking into the ED is definitely more now, as we had seen previously, or pre-COVID, if you see, it's starting to increase. So the access has been enhanced, more are walking in, but because of the exit block, we are not able to accept more in, and there is absence of base specialties. Now, this is a major reason why the extended length of stay is also seen. We do not have base specialties in PGI, and therefore we can't just divert some of these super specialty patients to those units which are already flooded with their patients and cannot accept them. So at a point of time when they are more resuscitated, more stabilized, more organized, they can be moved into these base specialty segments. So we don't have these base specialties in PGI. This is another reason why this length of stay is a little more. And we have limited community care resources where we could divert these patients once they are resuscitated and stabilized from these centers if they are not accommodated in PGI. So we don't have those sort of setups as yet. And there is lack of integration, obviously, between the community and hospital-based resources. So these are multifactorial. So we can't pinpoint that this is the most important reason, but these are a combination of these which is leading to this extended length of stay. Obviously, the crowding is happening because of this extended length of stay, which is leading to an increased mortality, is increasing the length of stay. Again, it is, I told you, it is double-edged. It is leading to one leads to the other. And there is, if there is extended length, so there is delayed time to critical interventions, so less frequent and less adequate pain relief will be there. There will be delayed antibiotic administration that will be happening. We have not counted it, but in the coming times, we will audit all these aspects as to how much is the delay. Increased risk of adverse events, yes, they are happening right now, and we need to count them out in the coming days and try and avert them. There is decreased departmental function because we are under-triaging, we are inferior care in terms of standard performance measures. There is increased number of patients who will be moving out without being actually seen, and there's blockage of the ambulance off-road. All these are consequences to what is happening now for a 30-bed ED. Just imagine it for a 210 BD, these problems may just get amplified 7 times. There is decreased patient satisfaction, there is increased staff stress and burnout, and less direct supervision and training of junior clinical staff. So this is happening for a 30-bed unit. Just imagine what might happen for a 210 bed. So these problems are going to just get amplified if there is going to be an exit block for these patients in coming times. So what are the solutions? Okay, some of them I could think of, and as the world thinks of these problems in terms of input, throughput, and output. We can tackle the input by moving on to, we are ready with that, for moving on to the 24/7 triage, the larger stretcher zone, a waiting zone for these patients, a more developed emergency medical support system, looking into issues of tele-ED where patients are just not walking in for non-urgent, so they can just have a telephonic conversation whether they actually need some ED interventions. So these are all areas which need to be worked on, and we are already actively moving into that direction. And then coordinated referrals. Who just walks in? Anybody who doesn't have a bed in the ward walks into the ED, or really a genuine patient walks into the ED who is having either an emergent or an urgent issue, not just because the ward bed is not available. And then there are throughput issues. Now, this is an area where we really want to work on, because we can increase the quality of care, we can increase the or reduce the disposition times of these patients, speeding up. And so this will go into protocolized ED care, bedside interventions, dedicated radiology services, dedicated POC labs, and then only we can go on to ED quality metrics, which are everyone in the world talks of these things. So this is where we have ultimately got to go. ED quality metrics, and then digitization of this entire throughput segment. The output block is something which is more beyond our purview, because we work in a super specialty segment with issues within the super specialty segment itself in terms of ward, manpower, and staffing and other issues. So exit block is something which can be worked out by more coordination and more apt understanding of that not taking these patients for whatever reasons may actually block the access of more patients who are more wanting for the ED care. And so manpower will hit everywhere. So you need manpower to work on inputs, you need manpower to better the throughput, you need manpower to tackle the exit block, both at the wards as well as the ED itself. So we can work onto these areas like 1, 2, 3, 4. Just look at the numbers and you can understand where things will go in the coming times. So the triage 24/7 by 365 by more experienced people, a waiting zone at the 2, more early disposition, the ambulatory section, more early disposition. If more staffing and more things are there, then examination room again, time bound. How much time does one take for a nurse to see the patient? How much time does a doctor actually see the patient? And how much time actually for an intervention? How much time for actually the reporting? How much time actually for the consultation for the primary unit? How much time from the consultation to the actual seeing? And how much time from the consultation to the discharge? And how much time from the discharge decision to actual discharge? So these are all time-based interventions which will come as we better our care bundles in the areas. And then we need this acute section, which has to be protocolized based ED care, guideline based, everything has to be in line. And then there is another option for the hybrid ED units that we think are going to be what we will probably have in the coming times, because we work in a super specialty division, super specialty with very limited beds in the super specialty segment. So we need these hybrid ED beds, which are co-managed beds, looking beyond, say, a 3-day interval where it is being supervised by us, but it is being manned by specialties or super specialties. So this will just help ease out the access block. It will help ease out the phase of the exit block. So this is one area. And yes, we do need an increased ward capacity everywhere around the clock. And at least for 2 departments, we can see at least which are occupying almost 70% of the ED, at least in the nephrology segment. We know the expansion plans are already there, but also for the gastromedicine department, which needs to probably expand. I can just say this. So if we need to transit this care from this type of care to this type of care, manpower will be important. Expansion infrastructure, yes, important, but manpower will hold the key if we want to transit from the left side to this type of care in the coming times. I would now request my colleague, Dr. O.P. Sanjeev, to go on to what the recommendations and the organizational and structural recommendations for the pan-India emergency developments are being set by the NITI Aayog.
Thank you, sir. Good morning, each and everyone. Now we will be working through some slides to cover the observation and key recommendations of the NITI Aayog. Before jumping over to the observations of NITI Aayog, I would like to take you to the pattern of causes of mortality projected by WHO Global Health Estimate for 2015 and 2013. That is for Southeast Asia region, and India is no different. So if you look carefully on this slide, we will find that non-communicable diseases are the major causes of death in Southeast Asia region, and it makes around 63% of all deaths for 2015. Amongst non-communicable diseases, cardiovascular diseases are the major culprit, and it share almost half of all deaths due to non-communicable diseases. That makes around 28%. And if we compare the data of 2015 to the projected deaths of 2030, we will find that there is further jump in deaths due to non-communicable disease from 63% to 72%. That is a jump of almost 9%. The pattern is similar for cardiovascular disease, because we can observe there is a jump of around 4% from 28% to 31.6%. So non-communicable diseases are increasing in number, and deaths due to non-communicable disease will also continue to increase by 2030 and so on. As far as injuries and trauma are concerned, obviously death of 11.3 is very high figure for deaths due to trauma and injury, but in the projections of 2030 with WHO, there is no increase anticipated for deaths due to injuries or trauma. Now, our report was prepared by a collaborative research group initiated at Emergency Medicine Department of AIIMS New Delhi, and the report was submitted to the Niti Aayog. We will be working through some slides to discuss the observations and recommendations of Niti Aayog. Actually, the collaborative group earmarked 100 centers for collection of data across the country. They divided the country into 5 zones. They collected data from all 5 zones. They collected data for one continuous year. They also sent their national level assessors to the centers of enrollment, and they collected live data for 24 hours. The collected data went into the phase of data analysis. It was analyzed in terms of hospital wise, also compared zone wise, and thereafter according to NABH accreditation wise. After analysis of all data, the report was submitted to Niti Aayog. If you look further into it, it was very robust mechanism tools to collect the data, compile the data, and analyze the data. And thereafter, after further discussion, the report was submitted to Niti Aayog by AIIMS New Delhi. There one observation is very important in regard of physical infrastructure of emergency department. They ranked the hospitals from rank 1 to rank 5 based on certain parameters that is written on the left side of the slide, like separate access for ambulance, designated area for ambulances, demarcated triage area, emergency department with adequate space, dedicated minor OT, point of care lab, police control room, a smooth entry area, adequate waiting area for patient and their relatives, safe drinking water. And the data from the medical colleges or government hospitals were disappointing because they ranked either 3 or 4 or 5. Medical colleges were ranked 4 as far as the physical infrastructure of ED across the country is concerned. SGPGI-MS ED is fortunately fulfilled measure of all these criteria and stands at rank 1. This is our observation. This was not the part of the Niti Aayog study group. The second observation related with physical infrastructure is the number of beds served by the emergency medicine. We can see across the hospital categories ranging from the private hospital, larger private corporate hospitals, government hospital, medical colleges, the ED bed share was only 3 to 5%. For medical colleges, it was only 3%. At SGPGI, it is only 2% till date. If you compare the footfall of OPD and EMD footfall, the medical colleges witnessed 17% of total footfall of the OPDs. As presented by our PDCC student Dr. Swati, SGPGI in 2022 till July, the EMD visits share 5% of all total footfall of SGPGI. There are various reasons can be cited for the little less number of footfall at SGPGI ED, because we know we are referral center and we do not have the broad specialty department as mentioned by HOD, that we do not have base specialty like medicine, surgery, pediatrics, obs, gynae. So definitely we have the patients with complex illnesses, complicated diseases, deferred cases with involvement of multi-organ system. Now, summary of admissions through the emergency. Medical colleges across the country which were enrolled for this study had admitted 22.2% of their ED visiting patients. I wish to repeat, the medical colleges admitted 22% of all patients who reported to ED for admission. At SGPGI ED, as we presented earlier, 10% of visiting patients got admitted. The Niti Aayog report also had some observations regarding the operationalization of the emergency medicine in terms of standard operating procedures, policies, and protocols for the emergency medicine. They looked for emergency manual, the availability and policies and procedures for patient transfer in and transfer out, discharge summary, etc. And the report was very disappointing. Hardly any medical college had any emergency manual or policies for patient transfer in or transfer out. At SGPGI, we are in the process of preparation of the emergency manual, and the policies and procedure for patient transfer in and transfer out need to be prepared with interdepartmental collaboration, because emergency medicine department cannot prepare all such protocols on its own. As far as policy on handling death cases, triage policy in ED and disaster management is concerned, medical colleges stands on an average line. If you look at the policy on handling death cases at SGPGI ED, still we are struggling to find out an SOP for disposition of the broad dead patients or the death that happened on a stretcher before admission in HIS. So all these policies are in the process of formulation, and we are struggling from last 3-4 years to get an institute-based SOP to dispose all these things. Triage policy in ED, we had prepared a score-based triage policy, but it is still to implement because there are various factors which makes it little problematic or makes it not feasible to get it implemented. As far as disaster management is concerned, in new EMRTC building, that is new building of the emergency medicine, there is an earmarked ward with necessary prerequisites with separate entries, separate exit, separate washroom, etc. is there, and SOP is in process of making. The report submitted by AIIMS New Delhi also looked for the availability and practice of certain important protocols related with emergency medicine, like emergency care protocol for cardiac arrest, emergency care protocol for stroke, emergency care protocol for chest pain, emergency care protocol for sepsis. Largely, medical colleges were deficient in practicing or having a written protocol for emergency care for cardiac arrest or for stroke or for chest pain or for sepsis. At SGPGI, we follow the ACC AHA guideline for cardiac arrest, and the emergency medicine manual. We are also preparing our own protocol for handling cardiac arrest in ED. As far as emergency care protocol for stroke and chest pain is concerned, the institute is already running a project, that is Golden Hour project, where there is a committee has been formed for interdepartmental coordination and collaboration to come out with a final guideline handling stroke and chest pain, because both are time sensitive diseases. So Golden Hour project at the institute level is still in phase of preparing a report and submitting a report. As far as emergency care protocol for sepsis is concerned, it is in the process of finalization. The report submitted by AIIMS New Delhi also looked for the operationalization and availability of ambulances at different categories of hospitals across the country. Unfortunately, 98.5% ambulances were found running with dead bodies of road traffic accidents. 90% of ambulances without any equipment or oxygen cylinder. 95% of ambulances were running without trained personnel, and there were huge misuse of government ambulances. So in this regard, Niti Aayog recommends that there must be at least one ALS type, I repeat, one ALS type of ambulance for any hospital that has more than 300 inpatient beds. For more than 500 beds, a hospital must have 2 ALS type of ambulances. After observation, I have mentioned just some of the observations. The report constitutes almost 100 or 150 observations. Now I will take you through the key recommendations of the report. The first and foremost recommendation is we need to develop a robust integrated emergency care service system which can comprehensively address all medical, surgical emergencies inclusive of trauma-related care. Regarding operationalization of the emergency medicine, they recommend we need to standardize protocols, SOPs for emergency care, inclusive of triage, to have a common optimal nationwide policy. To establish an academic emergency medicine department to ensure continuous ongoing medical education and development of skills for doctors, nurses, and paramedics. To develop mechanisms to ensure free treatment for emergency care services for all citizens, covering the minimal required period for early stabilization. So how do we
Dr.
see
Sanjeev, are you
future?
about to end your talk now? Is the talk ending now, or do you have
Sir,
many
but
more slides?
just 2 minutes, sir.
Yeah, please.
Just 2 slides. I'll finish quickly. So how do we see the future of emergency medicine in India? It looks that future of emergency medicine in India is bright as demand and potential are both rising. Academic emergency medicine departments have already been mandated by NMC in all recognized medical colleges. There is huge potential for human research development in emergency medicine and emergency medical services. And it is likely that ED will not just be ED in coming days, rather it will get transformed to an acute care facility working in coordination with all departments. It shall be based on time sensitive quality metrics, and pre-hospital care is and continue to be important, and it will observe the India will observe a huge development in pre-hospital care. Tele ED and more digitized ED is the futuristic emergency medicine of India. So we need to connect all dots from the site of injury, from the scene of injury during transportation up to the hospital-based emergency medicine to make a robust system of emergency framework in the country. To summarize, emergency medicine is an upcoming, demanding, and dynamic specialty. Academic emergency medicine department are being established with improvements in clinical, academic, and research. Issues of ED length of stay and overcrowding are multifactorial and need administrative support and better interdepartmental coordination and collaboration to improve. Hybrid ED units are needed in hospital where base facilities do not exist, and ED ICUs are needed to better manage sepsis and other MODS cases. Adequate staffing is essential to work on overall aspects of input, throughput, output of ED. It is privileged working in ED, so you must take pride in doing so. Thank you very much.